Today we are discussing radiotherapy in head and neck. So, coming to the history, the first in 1896, the first patient was treated 2 months after the discovery of the X-ray. 1950s with cobalt unit followed by linear accelerator. A few years later were developed. Radiotherapy plays a very important role in the treatment planning with rising significance of organ preservations and better cost basis. So, what is the aim of radiotherapy? To deliver tumoricidal doses to the disease while limiting dose to the surrounding tissue. To deliver the tumoricidal dose to the disease while limiting the dose to the surrounding tissue. Radiotherapy can be used as both radical and palliative therapy. So, radical radiotherapy. Coming to the radical radiotherapy, when used with the intent of eradications of the disease. Early stage disease inoperable, medical contraindication, surgery is morbid. 21 grays in 3 times daily fraction, 25 grays in 5 daily fractions over 1 week, or 35 grays in 10 daily fractions, 10 daily fractions over 2 weeks. So coming to what is palliative radiotherapy, to limit complications and improve the quality of life, control of pain or necrosis by relieving the pressure on the dural structures, lesions that obstruct the airway can be palliated by the tumor shrinkage. Control of the hemorrhage from the bleeding tumors, examples include 20 grays. See this 20 grays in 5 daily fractions over 1 week, 30 grays in 10 daily fractions over 2 weeks, single fractions of 10 to 12 grays. So what is the mechanism of action? So we'll discuss the mechanism of action. So when a photon beam interact with matter, they produce secondary electrons. Secondary electron ionizes tissue in their path, causing cell damage. Ionization. So single stranded breaks within DNA and double stranded breaks. So sublethal damage. What is sublethal damage? So DNA damage that can be repaired given the right cellular conditions and time. It is less efficient in tumor cells than in normal cells. More DNA damage is repairable with uh, smaller doses. So factors influencing the effectiveness of radiotherapy. 1 grays increase in effective total dose increases the loco-regional control by 1%. 1 grays, so 1%. 1 grays increase in effective total dose. Concurrent platinum-based chemotherapy, cetuximab, etc. So these increase the effect. That's why we give the concurrent chemotherapy also. Delays in commencing radiotherapy. Treatment interruptions. Local control falls by 4.4% per day. This is very important. Anemia at the end of the treatment, hemoglobin to be maintained more than 12 gram per deciliter. So before sending for the patient for the radiotherapy, we get the all the basic routine investigation done. Smoking, carbon monoxide displacing oxygen from the hemoglobin. So what's the concept of volume? So we'll see 4 terms related to the volume. Gross tumor volume, defined as the visible tumor volume in images. This is ZTV. GTV, gross tumor volume. CTV, clinical target volume, defined as gross tumor volume plus subclinical invisible invasion. You can see that this is CTV. Okay. ITV, internal target volume, defined as CTV plus IM. CTV is clinical target volume, IM is internal margin for organ motions. PTV, planning target volume, defined as ITV plus SM, setup margin for setup error. So radiotherapy fractionations, dividing of the total dose of the radiations to be administered into multiple doses. This allows for normal tissue repair in between fractions. This allows for normal tissue repair time in between the fractions. Hypofractionations, shorter regime, fewer fractions, and lower doses per fractions. Courses of treatment using larger fraction sizes than 2 grays are known as. So courses of treatment using larger fraction sizes than larger fraction than 2 grays are classified as hypofractionated. Hyperfractionation, same or greater dose given in smaller fraction in higher number, that is less than in higher number. Same or greater dose is given in smaller fractions and in higher numbers. So, for example, less than 1.8 grades, 1.8 grades, reduce the risk of late damage of the given total dose. Increase in risk of late damage, that we have divided the dose. So, increase in overall treatment time, resumes delivering 50 to 60 fractions. Example, 81.6 grades in 68 fractions over 7 weeks. What is accelerated fractionation? Combining acceleration with hyperfractionation, and treating 2 or 3 times each day. Reduce risk of normal tissue damage, shorter overall time. Minimum 6-hour interval between fractions is preferable. Chart. What is chart? Continuous hyperfractionated accelerated radiation therapy. So this regime combines accelerated and hyperfractionation. So radiotherapy delivery. Coming to the radiotherapy delivery, teletherapy or external beam radiotherapy, radiation beam is directed from a machine placed outside the patient. Brachytherapy, radioactive material can be introduced directly to within the tumor or tumor bearing area. So brachytherapy is given by iridium 192 wire. Applicators, what are applicators? So radio opaque hollow needles or tubes. The sources are then introduced after load after taking the patient to a radiation protected side room. So low dose rate LDR brachytherapy delivers continuous radiations at 40 to 200 centigrades per hour, linked to fractionated radiations with an infinite number of small individual doses. So what is high dose rate HDR brachytherapy? Delivers radiation excess of 1200 centigrades per hour, have a higher risk for complication involving late responding tissues. Thereby, it needs to be well fractionated to deliver only 1 to 3 fractions per week. Then interstitial brachytherapy for carcinoma of the tongue. We can see this. Advantages: provides a means of delivering a high dose to a small area. So the dose to adjacent normal tissue can be kept within the accepted limit, thereby reducing the side effect. Limitations: needed for adequate radiation protections. Technique is not appropriate when wider field radiation is required, for example, to cover the adjacent nodal areas. So brachytherapy, both as primary and post-operative treatment for oral cancer, has been largely replaced by resections and repair with free flash, but is still sometimes used for recurrent disease in the neck or nasopharynx. Teletherapy, also known as external beam radiation therapy. Teletherapy is also called as external beam radiation therapy, EBRT. So coming to the linear accelerator. So it increases the kinetic energy of the charged subatomic molecules or ions by subjecting them to a series of oscillating electric potential along a linear beamline. So it increases the kinetic energy of a charged subatomic particles or ions by subjecting them to a series of oscillating electric potential along a linear beamline. Beams of 4 to 6 megavolt are most appropriate for the treatment of head and neck cancer. This is very important. So electron beams can treat to depths up to 5 centimeter also according to the beam energy. So you can see that this is treatment head, source of external cylinder. These are collimators, field size. So this is the field size. You can see that this area is insulated. So what is immobilization? Accurate dependence on maintaining a stable target volume to maintain the STV, stable target volume. Individually molded thermoplastic cells covering the head and neck area. Reference marks are placed on the outside of the cell, avoiding the need for any skin marks or tattoo. So what is the setup required? Wedges alters the dose distribution due to the greater absorption of radiation through the thicker end of the wedge. Shields protect structures for radiations. Okay. Incident, this is wedge. So coming to the recent advances in the external beam radiotherapy, IMRT, intensity modulated radiation therapy with least side effect. This is most commonly used. IGRT, image guided radiation therapy. So intensity modulated radiation therapy, radiation therapy in which non-uniform radiation is delivered using non-uniform radiation. Is delivered using computer-aided modulation for optimizing the intensity of the radiation to be delivered at each point, allows higher radiation dose to be focused allows higher radiation dose to be focused to region within the tumor while minimizing the dose of the surrounding normal critical structures. Also allows for more homogeneous dose distributions inside the PTV. Image guided radiation therapy. So the radiation is planned and delivered based on anatomic information such that the result dose distribution conforms very closely to the target volume. No acceptable deviations from the original treatment plan. IGRT image guided radiation therapy involves both fitting the linear accelerator with CT capability. Images of each beam can be obtained, stored, and reviewed electronically. Newer generations of machines, example tomotherapy or types of rapid arc combines intensity modulated radiation therapy or image guided radiation therapy. फिर देखिए pre-operative radiation therapy, dose of approximate 5000 centigrade using conventional fractionation of 180 to 200 centigrade delivered 5 days per week for a treatment of up to 5 weeks. Dose of approximately 5000 centigrade using conventional fractionation of 180 to 200 centigrade per fraction is delivered over 5 days per week for a total of 5 weeks. A 4 to 6 preoperative radiation therapy. We are discussing the preoperative radiation therapy. A 4 to 6 week period of rest is allowed for the patient to recover and the acute inflammatory reaction to subside before surgical excision. So what are the advantages? Reduces tumor bulk, oxygenations to the tissue adequate. Lymphatics are blocked by radiation, so dissemination of tumor is less. Eliminates microscopic spread beyond the palpable tumor mass. So coming to the post-op radiation therapy, it is indicated when estimated risk of local regional recurrence of disease is less than or equal to 20%. It should be initially within 6 weeks of surgery to maximize the benefits. Post-op radiotherapy dose for the primary tumor site and or the neck region using conventional fractionation consists of 180 to 200 centigrade fraction per day, administered 5 days per week up to the total dose of 6000 to 6300 centigrades for the high risk areas and 5000 to 5400 centigrades for the elective nodal irradiation. So what are the indications? What are the indications? Primary tumor factors, locally advanced T3 or T4, high grade histology. High grade histology, this is very important. This we forget to say in Viva. Presence of perineural or vascular invasion, concerns with adequacy of procedure irrespective of the histological state of surgical margin, infiltration rather than pushing borders of the tumor, positive or closed margin of the surgical resection. So coming to the cervical nodal factors, N stage higher than N1, surgical contamination, example excisional or incisional biopsy prior to the definitive surgery, presence of gross intracapsular extension. So what is the advantage? Advantage of this spot. So advantages: no treatment related delay in the surgery. No treatment related delay in the surgery allows complete surgical, histopathological, and biological evaluations. Residual microscopic disease can be sterilized more effective. Bulk of mass removed. Post of healing better. Extent of tumor is known, so radiation is given to the suspected area. Disadvantages: potential for delay in initiation of radiation therapy if recovery from the surgery is complicated by fistula or other wound problems. Scarring and vascular modifications from surgery may decrease tissue oxygenation and adversely affect radiation tumor cell kill. Uh, Coming to the sandwich radiation therapy, pre-operative radiotherapy followed by surgery, which is followed by the post-operative. Pre-operative radiotherapy followed by surgery, which is followed by the post-operative radiotherapy. A type of split course irradiations with a break in the irradiation during which the surgery is performed. So, what is sandwich radiotherapy? Pre-operative radiotherapy followed by surgery, which is followed by the post-operative. So, surgery is sandwich between the pre-op and post-operative. That's called sandwich radiotherapy. A type of split course irradiation with a break in irradiation during which surgery is performed. Re-irradiations. What is re-irradiation? It is considered if adequate salvage surgery is not feasible or if concerns exist about margins after salvage surgery. Generally is to minimize radiation dose to critical normal tissue, that is spinal cord, optic tract, etc. Intensity modulated radiation therapy, addition of chemotherapy increases the effectiveness. So coming to the CLRs. So for glottic tumors, most stages T1, T2, or N0 glottic tumors are treated with radical radiotherapy with surgery reserved for salvage after radiotherapy failure. So preserves natural voice and avoided tracheostomy. This is the advantage. For T1 lesion, the radiotherapy portal spreads from the lower border of hyoid bone superiorly to the lower border of cricoid inferiorly. Anteriorly, the filled border should be in air at the filled center and posteriorly through the anterior part of the vertebral body. For T2 tumors, this was for T1. So T1, what we have seen कि our radiotherapy portal superiorly higher तक जाएगा, inferiorly cricoid cartilage तक जाएगा, anteriorly air at the field center, और posteriorly कहाँ तक जाएगा, anterior body of vertebral body. फिर देखिए for T2 tumors, see for T2 tumors the field size is extended based on the supraglottic or subglottic disease extension. In case of extensive subglottic extension, it is recommended that the paraesophageal and paratracheal lymph nodes are included. So those prescriptions depends on the field size as follows: less than 36 centimeter squares, 50 grays in 16 fractions, treating daily 5 fractions a week. 36 to 42 centimeter square, 55 grays in 20 fractions, treating daily 5 fractions a week. More than 42 centimeter square, so 64 to 66 grays in 2 grays per fractions, 2 grays per fractions, treating daily 5 fractions a week. So this is so about the supraglottic tumors, how radiotherapy is given in supraglottic tumors. Radical radiation, most early T1, T2, and 0 supraglottic tumor. All patients require elective nodal irradiations of these levels. Phase 1, primary tumors, larynx, preepiglottic space, and cervical lymph nodes bilaterally in level 1B, 2, and 3 anterior to the spinal cord. Phase 2 includes primary tumor and larynx only. The total dose is 66 to 70 grays in 2 grays per fraction, treating daily 5 fractions a week to microscopic disease, and 44 to 50 grays in 2 grays per fraction, treating daily 5 fractions a week to microscopic disease. So phase 1, superiorly mastoid process, inferiorly cricoid cartilage, posteriorly mid-vertebral body, anteriorly anterior border of level 1B. Phase 2, primary tumor with 1-2 margin, superior border reduction to the level of higher border. So coming to the subglottic tumors, usually require surgery for patients with early stage disease. Definitive radiations is recognized. Larynx preservation approach. The radiation portal should extend from the top of the thyroid cartilage superiorly to the mid-tracheal inferiorly. Dose prescription is 66 to 70 grays in 2 grays per fraction, treating daily 5 fractions a week. So locally advanced disease of the larynx, stage 3, 4 tumors of the glottis, supraglottis, subglottis are treated with primary chemoradiation as an alternative to surgery and POD. Used where patients are not fit for surgery or chemoradiations due to pre-existing comorbid conditions. Target volume, coming to the target volume, larynx, pre-epiglottic space involved lymph nodes, and all lymph nodes areas at risk of involvement with occult metastasis, namely level 1B, 2, 3, 4, and 5 in all patients bilaterally. The total dose is 66 to 70 grays in 2 grays per fractions, treating daily 5 fractions a week to microscopic disease, and 44 to 50 grays in 2 grays per fractions, treating daily 5 fractions a day. So phase 1 is proton beam, phase 2 is electron beam, phase 3 is proton beam superior. So coming to the oropharynx, coming to the oropharynx, divided into the 4 main subsites. So exam questions can be asked. In exams, question can be asked subsites, 4 main subsites of oropharynx, then tonsil, tongue base, soft tonsil, tongue base, soft palate, and posterior pharyngeal valve. When a lesion is well lateralized, unilateral irradiation technique may be employed. Midline tumors such as tongue base, soft palate may metastasize to either side of the neck anesthetizing bilateral neck radiation (IMRT) is preferred. So tonsil, the large volume of the microscopic dose include the tonsillar fossa, while the ipsilateral cervical lymph nodes level 1B to 4 are treated to be microscopic dose. For the extending from hard palate superior to the lower border of the hyoid bone inferior. The total dose is 66 to 70 grays in 2 grays per fraction, treating daily 5 fractions a week to microscopic disease, and 44 to 50 grays in 2 grays per fractions, treating daily 5 fractions a week to microscopic disease. फिर tongue base treated with radical chemoradiations. Small tongue based tumor T1 T2 presents early and zero, particularly exophytic tumors without fixity. So we can give radiotherapy filled hard palate superiorly to the hard palate superiorly to the lower border of hyoid bone inferiorly, filled hard palate superior, about filled hard palate superiorly hoga to the lower border of the hyoid inferiorly. Anteriorly includes level 1B lymph nodes or 1 centimeter anterior to the tumor, which is the more anterior. Posteriorly includes the posterior level 2 centimeter. Posterior level 2 and level 5 lymph nodes. The total dose is 66 to 70 grays in 2 grays per fraction, treating daily 5 fractions a week to microscopic disease, and 44 to 50 grays in 2 grays per fraction, treating daily 5 fractions a week to the microscopic disease. So soft palate, the target volume within a 2 centimeter margin. The total dose is 66 to 70 grays in 2 grays per fraction, treating daily 5 fractions a week. Hypopharynx. 3 recognized sites: the pyriform fossa, post-required regions, and postopharyngeal, characterized by the high incidence of nodal metastasis as well as some mucosal spread. Even in the cases of early primary tumors, elective nodal irradiations is necessary. Pyriform fossa, the target volume includes the primary tumor and level 1B to 5 lymph nodes bilaterally. The total dose is 66 to 70 grays in 2 grays per fractions, treating daily 5 fractions a week to the microscopic disease, and 44 to 50 grays in 2 grays per fractions, treating daily 5 fractions a week to the microscopic disease. Posterior pharyngeal wall and post-required regions. So primary tumor with the 2 centimeter posterior pharyngeal wall or 5 centimeter post-required margins, craniocaudally, and level 1B to 5 lymph nodes bilaterally. The total dose is 66 to 70 grays in 2 grays per fractions, treating daily 5 fractions a week to microscopic disease, and 44 to 50 grays in 2 grays per fractions, treating daily 5 fractions a week to the potential microscopic disease. Nasal cavity and paranasal sinuses. Main sites: maxillary sinus, ethmoid sinus, and nasal cavity. Combinations of surgery with the radiations or chemotherapy, since most lesions present when they are locally advanced. For definitive radiations is possible, however, for the occasionally early tumor. It may also be offered for advanced unresected disease. Maxillary sinus. Maxillary sinus, ethmoid sinus, and nasal cavity. The total dose is 66 to 70 grays in 2 grays per fraction, treating 5 fractions a week. Ethmoid sinus, in this the radiation volume should include ethmoid sinus, nasal cavity, medial half of the maxilla on the ipsilateral side, and the pterygoid fossa. The total dose is 66 to 70 grays in 2 grays per fraction, treating daily 5 fractions a week. Nasal cavity, primary lesion, and a 1 centimeter margin. So the total dose is 66 to 70 grays in 2 grays per fraction, treating 5 fractions a week. Nasal columella or vestibule. Radiation is often taken in the first instance to avoid deformity. CTV include the primary tumor with the 2 centimeter margin. The dose description for interstitial brachytherapy is 60 grays over 6 days with the radium 192. For EVRT, the total dose is 66 to 70 in 2 grays per fractions, and treating daily 5 fractions a week to microscopic disease. 44 to 50 grays in 2 grays per fractions, treating daily 5 fractions a week to microscopic disease. Oral cavity includes the oral tongue, floor of the mouth, buccal cavity, alveolus, and hard palate. Most oral cavity tumors are best treated with surgery followed by adjuvant radiations with or without chemotherapy. However, small T1, T2, superficial less than 5 centimeter, less than 5 millimeter thickness lesions of the oral cavity and the floor of the mouth should be considered for interstitial brachytherapy. tongue and floor of the mouth. Small superficial lesions, interstitial brachytherapy for patient unsuitable for brachytherapy but also not suitable for surgery. External beam radiation therapy may be offered. CTB includes the primary tumor with the 2 centimeter margin. The dose prescriptions for interstitial brachytherapy is 60 grays over 6 days with iridium 92 LDR. For EVRT, the total dose is 66 to 70 in 2 grays per fractions. Treating daily 5 fractions a week to macroscopic disease 44 to 50 grays in 2 grays per fractions. The daily treating daily 5 fractions a week to the microscopic disease. Buccal mucosa, alveolus, and small heart palate are almost invariably treated in the post-op setting. So coming to the radiation toxicity, what is acute toxicity? So I think we can do the radiation toxicity in the next session.